in my experience, patients don't really love a pivot based on new information.
How do you put this into context in terms of their risks, in terms of what their next steps might be?
I really try to do the 10,000-foot view at the initial consultation. So I do, and I make drawings. If we achieve a complete response, and what does a complete response mean, then we're going to go down path X. If we don't achieve a complete response, we can still get to a good place, but we have to do something different. And so I really do try and map things out for patients up front, because in my experience, patients don't really love a pivot based on new information. So I do have the luxury of spending a lot of time with my patients at the onset, so I can kind of give them the whole overview of the different ways in which this could play out.
I think by the time patients get to that surgery point, you've seen them through their neoadjuvant therapy. Mm-hmm. They're kind of expecting, you can prepare them that we're expecting to get, I don't want to call it an answer because it is an outcome for them that is a cure. I really try to emphasize to my patient that the surgery is the cure, and everything after that is extra therapy to make sure that cure rate is maintained or stays.
I agree. And those follow-up appointments are great opportunities to remind them what you talked to them about up front, because they only hear 20 to 30% of what you tell them in the initial consultation. It's also why I like to map things out in writing, so they have something to take home with them, to review with their family, to discuss, to remind themselves of the conversation. But then each of those subsequent appointments is another opportunity to remind them of where we're going and the decisions that we'll make down the road, because people usually need to hear things more than once. I know I do.
Yeah.